All right. Today's webinar for the UNC Lineberger Cancer Network's Research to Practice series is Update in Bladder Cancer with Dr. Matthew Milowsky. Dr. Milowsky's bioinformation can be found here and read in detail in today's handout. But before we get started, I'm going to introduce him with a few professional highlights. Dr. Matthew Milowsky, MD, is the George Gabriel and Francis Gable Villere Distinguished Professor of Bladder and Genitourinary Cancer Research. He is the Vice Chief for Research and Section Chief of the Genitourinary Oncology Service in the Division of Oncology at the University of North Carolina, Chapel Hill. He also serves as a program leader for clinical research and co-director of the Urologic Oncology Program at UNC Lineberg Comprehensive Cancer Center. Dr. Milowsky is a medical oncologist and clinical translational researcher. His clinical interest is in the treatment of patients with genitourinary cancers with a focus on the care of patients with advanced bladder cancer. Dr. Milowsky, thank you for joining us and presenting for us today.
Thanks so much, Andrew, for the kind introduction. It's really a pleasure to be able to present today on a topic that's particularly exciting for me. I appreciate the opportunity to talk about bladder cancer.
Yeah, we are too. Thank you. And just before we get started, as promised, we will be using Poll Everywhere. So this is your chance now as an audience member to log into pollev.com/UNCLCN or click on the link in the chat. This is your chance to try out our software. And while you're doing that, I'm going to flash up our ACCME and ANCC disclosures, which again can be read in more detail in the handout. So for our first Poll Everywhere question, MIBC is the abbreviation for muscle-invasive bladder cancer. How are they doing so far, Dr. Milowsky?
I think we're good to go.
All right.
So again, thank you very much. It's a pleasure to be here, and I'm excited to talk about updates in bladder cancer because I think, as many who are on this call are aware, there's been really enormous progress over the past decade plus. These are my disclosures. So the goals of today's discussion are to talk about the role of biomarkers in the management of bladder cancer, to understand the role of perioperative therapy for muscle-invasive disease, and then to review treatment strategies for advanced or metastatic disease. And so the way I'm going to do this is I'm going to divide the talk into different sections. And the first area of interest will be for the use of neoadjuvant therapy in patients with muscle-invasive bladder cancer. So what do we know? We know that neoadjuvant cisplatin-based combination chemotherapy is associated with an improvement in survival outcome for patients and represents a standard of care for the treatment of patients with muscle-invasive disease who are candidates for cisplatin-based therapy. And this is data from the Intergroup 80 study that was published in the New England Journal of Medicine in 2003. And there's also data from an MRC EORTC study that can be seen here. And bottom line is that cisplatin-based neoadjuvant chemotherapy improves overall survival by 5 to 7% compared to surgery alone. And again, it's supported by level 1 evidence. What we also know is that pathological downstaging with neoadjuvant chemotherapy is associated with improvement in patient outcomes or event-free survival outcomes. The issue is that the pathologic response is not a true surrogate at the individual patient or trial level for event-free survival outcomes. And so this has, in some ways, made it more complicated to be able to study this question in smaller studies. But here's data from the Intergroup 80 or SWOG 8710 study that I just showed you, demonstrating that pathologic downstaging is associated with improved outcomes. And this has also been evaluated on other experiences as well. And this is data out of Memorial Sloan Kettering Cancer Center, here showing that patients who achieve a less than PT2 or less than muscle-invasive disease at the time of cystectomy after neoadjuvant chemotherapy have improved survival outcomes. There has been a lot of work looking at different regimens in the treatment of muscle-invasive disease in the neoadjuvant setting. And so here's a series of studies here using different means of delivering cisplatin. There have been studies using chemotherapy. This is gemcitabine and cisplatin with immunotherapy. In fact, we led one of these studies at UNC with our colleagues at Duke. And there have been some studies that have looked at immunotherapy alone, that is, in the absence of chemotherapy. And you can see that the pathologic response rates range in the high 20s, upwards of 46%. But from this data, I think we would all agree, it's not possible to understand how these pathologic complete response rates actually translate into improvements in survival outcomes. And so, of course, there are phase 3 clinical trials that are looking at this question. Here are some studies: the Niagara study combining the anti-PD-L1 agent durvalumab with gemcitabine and cisplatin, and here Keynote 866 with pembrolizumab with chemotherapy. And what you can see from these studies is that they all actually include an adjuvant component as well. So they're not truly just neoadjuvant, they're actually perioperative therapy. And so what we have just seen from the ESMO meeting, and that was published at the same time in the New England Journal of Medicine, is the results from the Niagara study. And so this is looking at perioperative durvalumab with neoadjuvant chemotherapy in operable bladder cancer. And so this is the schema for the study. Here, resectable muscle-invasive disease treated with radical cystectomy. No prior systemic chemo or immunotherapy, and randomized to durvalumab and chemotherapy, gemcitabine and cisplatin with an adjuvant durvalumab component, or gemcitabine or cisplatin chemotherapy. And here are the co-primary endpoints of PCR and event-free survival. And what was seen in this study is that there was an improvement in pathologic response rate. This was the primary analysis, but then there was a reanalysis which included an additional 59 patients that weren't included within the primary analysis. And the pathologic response rate, this is complete response, was 37% versus 27%. But most importantly, there was an improvement in survival outcomes. So this is looking at event-free survival. So this is a measure that includes recurrence or progression or cystectomy at any time point, or not being able to undergo cystectomy at any time point, or death from any cause. And here the hazard ratio was 0.68, favoring the perioperative durvalumab in combination with chemotherapy. And then similarly, here is the hazard ratio for overall survival, 0.75, here favoring the treatment with perioperative durvalumab. And here are some landmarks at 12 and 24 months here, and you can see the improvements in survival outcomes. With regard to toxicity, quite similar. The grade 3 or 4 events were about 70%. If you look specifically at treatment-related adverse events of any grade, again, similar, and those of event grade 3 or 4, approximately 40%. And so this was reasonably well tolerated, and there was no compromise in the ability to undergo cystectomy in the perioperative durvalumab arm. And so, again, this is new data. It's really hot off the press, and we will see ultimately how the regulators view this study, but it could certainly represent a new paradigm for the way in which we think about treating patients with muscle-invasive disease. There are additional studies that are ongoing, and we'll talk more about this antibody-drug conjugate enfortumab vedotin as perioperative therapy. But here you can see that there are efforts to look at this in cisplatin-eligible as well as cisplatin-ineligible patients, and these are patients for whom they typically will go directly to cystectomy. There are potentially options for trimodality bladder preservation approaches with radiation and chemotherapy as well, which we'll mention. But in these neoadjuvant strategies, there are combinations of enfortumab vedotin and immunotherapy. And again, all of these have an adjuvant component. So you're really looking at perioperative strategies. EV304 and EV303 have completed accrual, and the Volga study's ongoing, looking at the issue of combining with durva or durva-tremi. The next question is it possible to select patients with muscle-invasive disease who do not need definitive management of the bladder? This is cystectomy or trimodality therapy, which I mentioned, which includes as complete a transurethral resection as is safely possible, followed by the combination of chemotherapy and radiation therapy as an attempt to preserve the bladder. And unfortunately, there have been historical barriers to really true bladder-sparing approaches. A paucity of prospective studies, lack of rigorous methods to measure and define a clinical complete response, a limited understanding of the role of delayed cystectomy in patients who develop a local recurrence, and suboptimal systemic therapeutic regimens, which I think is changing now as we're seeing some of these new combinations, new antibody-drug conjugates and targeted therapies, and ultimately the absence of biomarkers to ultimately refine our decision-making. There are data suggesting that mutations in DNA damage repair genes correlate with response to neoadjuvant chemotherapy. And so here's work by Ellie Van Allen and his group at the Dana-Farber showing that mutations in a nucleotide excision repair gene, ERCC2, was enriched in responders to neoadjuvant chemotherapy as compared to non-responders. And this is data by Dr. Plimak, who's at Fox Chase, showing that a series of DDRs, including ATM, RP1, and FANG-C alterations predicted response to neoadjuvant chemotherapy. And this also appeared to be associated with improvement in survival outcomes. In other words, harboring these DDR alterations and receiving cisplatin-based chemotherapy was associated with improvement in outcomes. And so with this in mind, there have been a series of studies that have tried to address this question or have been looking at this question. This is one study called the RETAIN study, which looked at a series of DDRs, and in patients, patients were then given chemotherapy. This is with accelerated MVAC, underwent a second transurethral resection, and if they were mutation positive and had no residual tumor, then they could go on to active surveillance. Otherwise, they were treated with the standard paradigm. And the primary endpoint was MFS at 2 years for the ITT. This study, I'm not going to show you all of the details, ended up not being a positive study due to the non-inferiority design. But there are other studies that are ongoing using slightly different approaches toward looking at this specific question of DNA damage repair, gene alterations, and the potential for bladder sparing. This is the RETAIN-2 study, which is looking at accelerated MVAC, but here combining it with immunotherapy with a similar type of trial design. And this is another study, the Alliance A031701 study, which is looking at a panel of DDR alterations, which includes some of the ones that I just mentioned, including ERCC2 and ATM and FANG-C, and then treating these patients with cisplatin-based combination chemotherapy. And then once again, in patients who have DDR alterations and have a complete pathologic response, these patients can go on to a bladder-sparing approach. This trial is continuing to actively accrue. There's another study, the HCR-NGU20-444, which is looking at neoadjuvant pembrolizumab in patients with muscle-invasive bladder cancer with selective bladder sparing here again. And so this is looking at that question of clinical restaging. In other words, how do we truly define that clinical complete response in patients? And here using cystoscopy with biopsies, urine cytology, MR imaging, to try to define that clinical complete response so we know which patients may ultimately be spared radical surgery. So this is our next polling question. How does pre-surgical neoadjuvant chemotherapy impact survival in bladder cancer patients? And so A is it has no significant impact on survival rates. B, it decreases survival rates. C, it improves survival rates. D, it only improves survival rates in early stage bladder cancer. Yeah, so most of you picked C. It probably isn't the best worded question. The answer is C, but I could see how some may have interpreted early stage as muscle invasive as compared to metastatic disease. What we're trying to get at is non-muscle invasive disease where there's not an improvement in survival outcomes, whereas there is in muscle invasive disease. So we talked about sort of neoadjuvant therapy, and we talked about these perioperative strategies. So what we will do next is talk about where things are in the adjuvant setting. And I'll set the stage by saying that to date, we do not have level 1 evidence for the use of cisplatin-based adjuvant chemotherapy. There are studies which have demonstrated improvements in outcome, but we have not seen large completed randomized phase 3 clinical trials that have demonstrated clear improvements in survival. In addition, what we also know is that cisplatin-based chemotherapy can be complicated to give in the adjuvant setting. In fact, one study by Donat et al. Demonstrated that it would be complicated in about a third of patients to be able to deliver adjuvant chemotherapy within 90 days of surgery, which is typically the window that we think about due to issues that came up as related to that postoperative period. And so with that in mind, there have been a series of studies that have looked at adjuvant immunotherapy or immune checkpoint blockade, more specifically with PD-1 and PD-L1 inhibition. And so these are the 3 studies. The first study is the IMvigor10 study. The next is the Checkmate 274 study. And the third one is Ambassador. And as you can see, these studies were not designed in an identical way. The Checkmate 274 study randomized patients to nivolumab versus placebo, so an anti-PD-1 versus placebo with a primary endpoint of DFS. The Ambassador study randomized patients to pembrolizumab versus observation with co-primary endpoints of DFS and OS, and again, this is a PD-1. And here we have a PD-L1 antibody atezolizumab randomized against observation with a primary endpoint of DFS. And what we saw in these studies, and I'll show you the details, is that the IMvigor10 study did not meet the primary disease-free survival endpoint. Checkmate 274 on the other end did in fact demonstrate an improvement in disease-free survival, which led to an FDA approval in August of 2021. And then the Ambassador study with pembrolizumab was initially presented, updated at ESMO, and just published in the New England Journal of Medicine with an improvement in disease-free survival. So let's take a closer look at these studies. This is the IMvigor10 study, and you can see, looking at the DFS Kaplan-Meier curve, that there is no improvement in DFS with adjuvant atezolizumab for a year as compared to observation. In a retrospective exploratory data analysis looking at circulating tumor DNA, what was seen is that patients with detectable ctDNA in this study were more likely to have a benefit from adjuvant atezolizumab monotherapy compared with patients without ctDNA. And here are the Kaplan-Meier curves looking at patients with regard to post-surgical ctDNA status. And so here's the probability of disease-free survival and overall survival. And what you can see is that circulating tumor DNA appears to be both prognostic and predictive with regard to outcome and response to atezolizumab. And so here, the ctDNA negative patients do better, and the ctDNA positive patients do better when these patients receive atezolizumab. The Checkmate 274 trial was designed a little bit differently, as I mentioned. This randomized patients with persistent muscle-invasive disease or T2 disease after cisplatin-based neoadjuvant chemotherapy, or in patients who did not receive neoadjuvant chemotherapy, they had PT3 plus and/or node-positive disease. And this was similar in the other studies as well, but here it randomized them to nivolumab versus a placebo. And the primary endpoints were DFS in the all randomized patient population, or the ITT, and in all randomized patients with tumor PD-L1 high, in this case defined as greater than or equal to 1%. These are the baseline characteristics of the patients. You can see that about 20% of the patients had upper tract urothelial carcinoma. You can see that the tumor PD-L1 greater than or equal to 1% was about 40%. And about 40% of patients received neoadjuvant chemotherapy. This is looking at the ITT, and this is breaking it down into patients specifically with muscle-invasive disease. So here, the DFS benefit is seen in the ITT population with a hazard ratio of 0.71. You also see that the hazard ratio is 0.63 in those patients with muscle-invasive disease. And when looking at patients with PD-L1 greater than or equal to 1%, the hazard ratio is even more robust. And so here's 0.52, and in the muscle-invasive cohort of patients, it was 0.44. And as I mentioned, this led to an FDA approval for the use of adjuvant nivolumab in this patient population. The EMA actually approved this only for patients with PD-L1 greater than or equal to 1%, due to the more robust hazard ratio seen in patients with PD-L1 positivity in the absence of a clear overall survival benefit to date. With regard to treatment-related side effects, here you can see that 18% of patients with grade greater than or equal to 3, and only 7% treatment-related AEs that led to discontinuation. And I think that, as we use more and more immune checkpoint blockade, we're quite used to the side effects that are associated with immune checkpoint inhibition. Finally, the ambassador study, more similar to the Vigor 10 study here, randomizing pembrolizumab versus observation. Here, the eligibility criteria were similar, although this did allow patients with positive surgical margins, although there were few in the study, and the primary endpoints were DFS and OS. Again, about 65% of the patients received neoadjuvant chemotherapy, PD-L1 positive status, and this was measured differently here. This was the combined positive score. Here, about 57%. Majority of patients with lower tract tumors. This is bladder. And then you can see that there were a few patients who had evidence of positive surgical margins, which historically had not been included within the adjuvant trials. And a very similar DFS benefit that we see for pembrolizumab in this setting with a hazard ratio of 0.69. But what was not seen is the marker behaving similarly. So here, it did not appear as though there was a predictive value to the marker with regard to improvement in the setting of use of the pembrolizumab. There may be some prognostic information from the marker, but again, this was measured differently, but certainly did not behave in the same way as the PD-L1 marker within the CheckB274 study. And to date, we do not have an overall survival benefit associated with the use of adjuvant pembrolizumab, only the DFS benefit. And again, this was just published in NEJM. These are the toxicities. Again, these are all AEs regardless of attribution. And I think, again, reasonably well tolerated with the caveat that, of course, in the adjuvant setting, we ideally would be liking to treat those patients who we know are at the highest risk for recurrence, such that we do not provide any toxicity to those patients who don't need adjuvant therapy. And of course, this is the whole issue with perioperative treatment. And it may be that we will have an answer to this in the future with ctDNA, as I showed you in the IMvigor 10 study. This is the IMvigor 11 study, which is taking patients who have positive ctDNA and randomizing them to atezolizumab versus placebo. And this is another study called the Modern study, which we have open at UNC, which is taking patients and those that are ctDNA positive are randomized to nivolumab versus nivolumab and relatlimab, another checkpoint inhibitor inhibiting LAG-3, as compared to those who are negative, get randomized to nivolumab versus surveillance. And if they develop detectable ctDNA, they can receive nivolumab. It's a really interesting study because it has this escalation, de-escalation strategy employing circulating tumor DNA. So our next polling question, which of the following adjuvant therapies showed a significant improvement in disease-free survival for patients with high-risk muscle-invasive bladder cancer in clinical trials? And so that's right. So let's wait. I've gone too quickly. Yeah. So the benefit was seen in the studies looking at nivolumab and pembrolizumab, so the two PD-1 inhibitors in CheckMate 274 and Ambassador, so both B and C, but this was not seen in the atezolizumab study with IMvigor010. So moving on to recent advances in metastatic disease. So we've seen a lot of change in the landscape for the treatment of patients with metastatic urothelial carcinoma. The standard of care for decades was cisplatin-based combination chemotherapy in patients who were eligible for cisplatin, and in patients who were not eligible for cisplatin-based chemotherapy. If they were eligible for chemotherapy, the choice would be carboplatin-based chemotherapy, so regimens like MVAC or gemcitabine and cisplatin, and gemcitabine and carboplatin for patients who were chemotherapy candidates but not cisplatin eligible. And then much like in other diseases such as non-small cell lung cancer, a number of studies looking to combine chemotherapy with immunotherapy, and some studies looking at immunotherapy combinations. And again, these are more specifically checkpoint inhibitors. And you can see a number of studies here, the IMvigor130 study, looking at the combination of atezolizumab with platinum-based chemotherapy, KEYNOTE-361 combining with pembrolizumab, the Danube study, which is looking at immunotherapy combinations, and then we'll talk more about the CheckMate 901 study. But what was seen in these studies were unfortunately not positive results. However, in sort of retrospective looks, it appeared as though there in subgroup analyses may have been a benefit in those patients that received cisplatin combinations with immune checkpoint blockade, specifically in IMvigor130 and KEYNOTE-361, as compared to carboplatin. Maybe something special about cisplatin had been raised. There was a small, what I would say clinically insignificant progression-free survival benefit that was seen for the combination of atezolizumab with platinum-based chemotherapy in IMvigor130. But no clinically significant improvement or survival benefit. This data led to an approval. This is the Javelin Bladder 100 study, which took patients who had received 4 to 6 cycles of platinum-based chemotherapy. And if these patients had a response or stable disease, they were randomized to maintenance of nivolumab, the anti-PD-L1 agent, versus best supportive care with a primary endpoint of overall survival. And in fact, what was seen in this study was that there was, in fact, an improvement in survival outcomes. Here's the hazard ratio of 0.69. The medians were 21 versus 14.3 months. And this led to a strategy of using switch maintenance with maintenance of nivolumab in patients who had a response or stable disease after upfront platinum-based chemotherapy. This is just looking at the overall survival from the start of the maintenance therapy, that is not from the initiation of treatment. And so again, overall survival was longer with nivolumab in best supportive care versus best supportive care. This was the case in both the cisplatin and carboplatin groups, and this led to the approval of maintenance of nivolumab after platinum-based chemotherapy. Well, on the heels of that, there's just been a tremendous amount of movement in the development of therapies. This is enfortumab vedotin, which I mentioned earlier. It's an ADC targeting Nectin-4. It's conjugated with a microtubule disrupting agent, monomethyl auristatin E, by a protease cleavable linker. And Nectin-4 is highly expressed in close to all urothelial carcinomas. This is data from EV301, which was a pivotal study looking at patients with metastatic disease who'd been previously treated with platinum-based chemotherapy or immune checkpoint blockade, and randomizing them to EV versus investigator's choice chemotherapy. This study, in fact, demonstrated a survival benefit associated with the use of enfortumab vedotin in that setting, as well as an improvement in progression-free survival. And EV was approved, and there have been subsequent studies that have led to subsequent approvals. And so this is really a trial with results that we have not seen before in this disease. This was initially presented at ESMO in 2023 by Tom Powles. taking patients in the first-line setting and randomizing them to the combination of enfortumab vedotin and pembrolizumab as compared to platinum-based chemotherapy. And here are the dual primary endpoints of PFS and overall survival. And the data is really astounding. This is the key demographics and baseline disease characteristics. So you can see that about 55% of patients were cisplatin eligible, 72% with visceral metastatic disease, about 20% with liver metastases, a difficult patient population to treat due to an aggressive disease. And here, the hazard ratio for progression-free survival was 0.45, so reduced by 55% that risk of progression or death. And then when one looks at the overall survival, the risk of death was reduced by 53% in patients who had received the combination of enfortumab vedotin and pembrolizumab. And so this, I think, has really transformed the landscape for the management of patients with advanced disease. The confirmed overall response rate was close to 70%, with a close to 30% complete response rate. And there were about 30% of patients in the chemotherapy arm that ultimately went on to receive maintenance nivolumab, and approximately 60% of the patients in the chemotherapy arm went on to receive subsequent PD-1/L1 inhibitors. And, you know, we always have concerns and ask questions about subsequent therapy that are associated with improvement in survival outcomes in patients to ensure that it doesn't confound the results of the study. Treatment-related adverse events that are important with enfortumab are things like peripheral neuropathy, as well as skin toxicity. There can be hyperglycemia and others. And I think, you know, we're beginning to use these agents more, and certainly the combination of enfortumab vedotin and pembrolizumab. And there's been some other data in the first-line setting from the CheckMate 901 study that I had mentioned earlier, looking at the combination of nivolumab plus gemcitabine and cisplatin versus gemcitabine and cisplatin alone for previously untreated patients with metastatic disease. And this study took patients again and randomized them in that first-line setting. They, of course, needed to be cisplatin eligible to the combination of chemotherapy plus nivolumab versus chemotherapy alone. And they were able to continue nivolumab up to 24 months. The primary endpoints were OS and PFS by BICR. And here are the patient characteristics from this study. Majority of patients had urothelial carcinoma of the bladder, about 20% of patients with evidence of liver metastatic disease. And these are the Kaplan-Meier curves demonstrating an improvement in overall survival with a hazard ratio of 0.78. These are the medians, 21.7 and 18.9 months. In favor of the combination of nivolumab and chemotherapy, as compared to, and here is, I should say, the progression-free survival hazard ratio of 0.72 in favor of the combination of chemotherapy with nivolumab. And so this also led to an approval for this combination. These are the objective response rate data. Here, the response rate for those receiving the combination was 57.6% versus 43% for the cisplatin and gemcitabine alone. The complete response rate here was 21.7% versus 11.8%. And what's particularly interesting is if you look at the median duration of response in those patients who achieved a complete response, it's 37.1 months. So really suggesting that there's something here in terms of the potential for durability. And there's been some retrospective look at this that was presented by Matt Galsky at FASCO, which suggested that approximately 18% of patients had lymph node-only disease, and the complete response in those patients was actually 63% with associated durability. And so, again, it's a subgroup analysis from this study, but a suggestion that it may be those patients who have historically done well with platinum-based chemotherapy, which is the lymph node positive patients. And it appeared to be, again, we get smaller subgroups, that it may be more likely to be patients that have more local regional lymph nodes as compared to distant lymph node involvement. These are the treatment-related adverse events for these patients. I'm not going to go into the details. You have these slides. But again, similar to what we see with chemotherapy, but also taking into consideration what we see when incorporating immune checkpoint blockade in terms of the specific toxicities. So I think if we look at these next to each other, what sort of stands out is that, yes, they both lead to improvement in survival outcomes, but I think that we'd all agree that there are certainly more robust improvements in outcome associated from the EV-302 study with the combination of enfortumab vedotin and pembrolizumab as compared to what was seen with gemcitabine and cisplatin in combination with nivolumab and CheckMate 901. Can we ultimately select patients for who may be better suited for one or the other? I think with time we may learn more, like I just mentioned, with regard to those patients with local regional lymph node involvement. Although, frankly, that may be the same population of patients that does particularly well with long-term outcomes with enfortumab vedotin and pembrolizumab. What about targeted therapies? This is data for the pan-FGFR1/4 inhibitor, erdafitinib, selecting patients based on FGFR mutations or activating fusions, which occur in about 15 to 20% of patients. Overall response rate in pretreated patients was 40%. You can see the median overall survival. Here's some updated data, specifically looking at the progression-free survival and the overall survival. So certainly promising outcomes in patients after chemotherapy, prior immunotherapy, using this targeted agent directed against FGFR3 in patients who harbor those alterations. There was a randomized phase 3 clinical trial, which has been published, the Thor study, which had two cohorts. Cohort 1 looked at patients with metastatic disease, prior treatment with immunotherapy or as a combination, less than or equal to 2 prior lines of systemic therapy. So these are really chemotherapy, immunotherapy treated patients, randomizing them to erdafitinib versus enflunine or docetaxel chemotherapy. And the second cohort looked at patients with no prior immune checkpoint blockade, only 1 line of prior systemic therapy, and randomized these patients to erdafitinib versus placebo. And the primary endpoint was overall survival. And so here in the first cohort, there was an improvement in survival. Here, the hazard ratio is 0.64, medians of 12.1 and 7.8 months. However, when looking at cohort 2, again, these are patients that did not receive previous immune checkpoint blockade with a primary endpoint of overall survival compared with erdafitinib. And again, these are FGFR3 altered patients. What you can see is that there is no improvement in survival outcome, and these curves actually cross. Based on these data, the FDA has approved erdafitinib, which it had previously done. However, it amended the approval to make it clear that it's not recommended for the treatment of patients who are eligible for and have not received prior PD-1 or PD-L1 inhibitor therapy. And this is based on the results from this randomized phase 3 Thor study. Other antibody-drug conjugates have also looked promising. This is one called sacituzumab govitecan, which I suspect many are aware of. It has an approval in breast cancer. It has an approval, it's accelerated in urothelial carcinoma. TROP2 is an epithelial cell surface antigen that's highly expressed in urothelial carcinoma. This is a ADC that's distinct from other ADCs. It's got a high DAR, or drug-to-antibody ratio, and I'll show you some of the data. So this is the Trophy U01 study. This is a multi-cohort phase 2 trial, and I'll go through some of these cohorts to give you a sense of what the response and event-free survival data looks like for patients receiving this agent. So in the first cohort, these are patients with metastatic urothelial cancer who progressed after prior platinum-based chemotherapy as well as checkpoint inhibitor-based therapies. Here, remember, the primary endpoint is subjective response rate. And what was seen in cohort 1 was a response rate of 27%. The median PFS was 5.4 months, and the median overall survival was 10.5 months. And, again, clearly activity in these patients. If one looks at cohort 2, which is patients with metastatic urothelial cancer who progressed after a checkpoint inhibitor and were platinum ineligible at the start of the study, what you can see is sort of similar response data here, 32%, and here the progression-free survival, 5.6, and the overall survival of 13.5 months. And then finally, this has been looked at in combination with chemotherapy. And so this is cohort 3 from the study, looking specifically at the combination of sacituzumab govitecan with the PD-1 antibody pembrolizumab in 41 patients. These are platinum refractory patients that are checkpoint inhibitor naive. And the response to therapy here is 41%. There was a 20% complete response rate, median PFS 5.3 months, median OS about 13 months. You can see that some of these responses appear more durable. And so these sort of combinations of therapies with novel mechanisms of action, specifically immune checkpoint blockade with antibody drug conjugates, are sort of coming at us very rapidly as we're seeing more and more ADCs being developed. The phase 3 TROPIC-04 study is very similar to EV301, looking at patients in previously treated metastatic disease with platinum-based and immune checkpoint blockade, randomizing to sacituzumab versus chemotherapy. And all we've seen to date is a press release that the study did not meet the primary survival endpoint. There was actually a higher number of deaths due to adverse events with sacituzumab, which were primarily observed early in treatment and related to neutropenic complications. And so we know that the side effects of these antibody drug conjugates like sacituzumab govitecan, which is combined with the toxin SN38, a topoisomerase I inhibitor, has more in the way of myelosuppression and GI toxicity. And so we look to see more of this data. We know that HER2 has been an interesting target to consider in bladder cancer for some time. It's overexpressed at the 2+3+ level in over 50% of urothelial carcinomas. This is data from the Destiny Pan-Tumor02 study. It was a study looking at in HER2 expressing solid tumors, and there was a bladder cohort within this study, and this was published in the Journal of Clinical Oncology and actually subsequently approved by the FDA. Here is the bladder cohort. You can see a response rate in 3+ patients of 56%, 35% in patients with 2+ expression. And when looking at specifically the bladder cohort in progression-free and overall survival, here about 7 to 8 months with PFS and approximately 13 months with regard to overall survival. And so this has led to sort of a tumor agnostic type approach based on HER2 3+ expression, although I think that we would also say that there appear to be interesting responses in patients with 2+ disease as well. Disitamab vedotin is another antibody drug conjugate that's directed against HER2, conjugated to the toxin monomethyl auristatin E, which is the same toxin for enfortumab vedotin. There's been a number of studies that have looked at this with more on the horizon. Here is disitamab vedotin. This was previously referred to as RC48 in patients with HER2 3+ metastatic urothelial carcinoma, response rate of 50%. You can see that it was higher in patients with IHC 2+ FISH positive or IHC 3+, but also very interesting activity in patients with visceral metastatic disease, as well as metastatic disease that involves the liver. This is the PFS data and OS data for the HER2 2/3+ cohort. This was published in JCO. So median progression-free survival of about 6 months and a median survival of approximately 14 months. Disitamab vedotin has also been looked at in patients with lower HER2 expression. Here, looking at HER2 1+, the response rate was 26%. And so there may be an interest in considering this for patients who have lower HER2 expression levels, which we've seen again begin to evolve in other diseases like breast cancer. Then here is disitamab vedotin plus toripalimab. So this is an anti-PD-1 therapy. And there was recently data actually that was presented at ESMO in a safety cohort of patients looking at disitamab vedotin plus pembrolizumab, which looked similar in terms of the response data, but here a confirmed response of close to 72%. So this is, again, very exciting looking. It looks very similar to the type of response that one sees when combining enfortumab vedotin with pembrolizumab, which I showed you earlier in the EV302 study. So, is there something special about combining, the antibody drug conjugates that have a toxin of monomethylaurstatin E with immune checkpoint blockade as compared to those that do not? That is, examples here include topoisomerase inhibitors as the toxin. There may be. Here, clearly, the EV pembro and disitamab vedotin toripalimab, and now the disitamab vedotin pembrolizumab data, which I haven't shown you, again, from a small group of patients within a larger study, demonstrates clearly higher looking response rates as compared to when we've combined, as an example, trastuzumab deruxtecan and nivolumab, or sacituzumab govitecan and pembrolizumab, which I've shown you. And so, I think that at the end of the day, we're really excited about all of the progress that's been made in the treatment of patients with advanced urothelial carcinoma of the bladder, as well as the urothelial carcinoma of the upper urinary tracts. Here is a schema from the EAU guidelines, which I've had the honor of participating in with colleagues in medical oncology from Switzerland, Anya Lorch, and with Richard Katomas here. If patients are combination therapy eligible, pembrolizumab and enfortumab vedotin represents really a first-line strategy. There are options, as I showed you, from Javelin Bladder 100, as well as from Checkmate 901 for both maintenance immunotherapy or combination cisplatin-based chemotherapy with immune checkpoint blockade. For those patients that are not eligible for a checkpoint inhibitor here, platinum gemcitabine could be considered, and then combination therapy ineligible. This is data for, again, the European Association of Urology. So atezolizumab is concluded. This would not be approved in the US, but certainly pembrolizumab is for patients who are not eligible for any platinum-based chemotherapy. And then a bunch of different options if we come down with regard to later line therapies. And I think that, we can envision a future where combinations of antibody drug conjugates along with immune checkpoint blockade may represent the future of first-line therapy. For example, in HER2-selected patients, there may be a preference to use HER2-targeted ADCs in combination with immune checkpoint blockade. That being said, I think that we need additional studies to really understand if that's going to be the best treatment strategy for patients. And I also think that the use of circulating tumor DNA, both in the perioperative setting, as well, potentially in the metastatic setting, to understand issues as related to minimal residual disease, are ultimately, hopefully, going to inform how we treat patients in the future. And so with that, I'm going to end. It's been kind of a whirlwind tour through some of the new data with regard to bladder cancer. This is our last polling question in the Javelin Bladder 100 trial. Which treatment group had a median overall survival of 21.4 months? Right. So Javelin Bladder 100, again, was really the first major change that we had to the standard treatment paradigm of platinum-based chemotherapy in patients with metastatic disease, incorporating that switch maintenance strategy with the PD-L1 inhibitor avelumab, which did, in fact, demonstrate a median overall survival of 21.4 months versus about 14 months in those patients who underwent chemotherapy followed by best supportive care alone. So the answer is A for this last polling question. And so this is where I work at the North Carolina Cancer Hospital, the Vast Night Cancer Hospital. And with that, I'm more than happy to take any questions. I think we left enough time to be able to have some questions from the audience. Thank you again for your attention.
And thank you so much for that presentation, Dr. Milowsky. Very comprehensive review of treatments. And just want to remind everybody that you can submit your questions to the presenter at polev.com/UNCLCN. There is a link in the chat that you can click on to submit your questions. And while we're waiting for those questions to come in, just a very generic question of my own. Regarding all these updates, are there any trends in the research that you're particularly excited about in terms of being able to quickly translate into clinical practice?
Yeah, I think what I mentioned at the very end, which is trying to best select patients, is going to be, I think, really the future. And I think that as we have more and more of these therapies being developed, there were some exciting work looking, as an example, at an EGFR HER3 antibody drug conjugate that was at the recent ESMO meeting. I think that we will hopefully be in a place where we can sort of analyze a patient's tumor and make decisions about, what is going to be the best opportunity for a target. And I'm also really excited about, the changes that are occurring in the muscle-invasive bladder cancer space, because I think that ultimately our goal, right, is to cure more patients. And I think as we bring therapies earlier that are very effective, then we have a real opportunity there for curing more patients with bladder cancer. And so again, taking these very active therapies in later disease setting and moving them earlier.
Okay, thank you. A couple questions are coming in too. First one, are there any updates on early detection and diagnosis?
Yeah, so, I would say that there are not any major updates that have presented recently with regard to early detection and diagnosis. Early detection has been difficult, and there have been obviously looks at different urine type testing to try to take populations of patients who are at higher risk, for example, those with a strong smoking history and other environmental exposures. However, unfortunately, we don't have anything recent that I would say is sort of on the horizon with regard to early detection. And in terms of diagnostic modalities, I would say that there are some new approaches toward looking at defining clinical complete response, as I mentioned, in patients toward bladder sparing type approaches using, new imaging type approaches with MR, using a VIRADS like we use, vesicle imaging like we use in prostate, PIRADS, to try to better understand who may have muscle-invasive disease or what the response is to upfront neoadjuvant therapy in patients who may have a clinical complete response. And so I think there's more to come with regard to specifically defining that clinical complete response to be able to hopefully allow patients to live with their bladders.
Very good. Good to know. Moving on, are there potentially subgroups of patients that would respond to immunotherapy and chemotherapy?
Sure. So I mentioned that already. I talked perhaps a little bit more about the issue of looking at DDRs, DNA damage response genes in patients that may confer exquisite sensitivity to cisplatin-based chemotherapy. I think with antibody drug conjugates, the truth is, as we know, that delivering these toxins is delivering chemotherapy in a different way. And so, as an example, there was data recently that was published in JCO suggesting that Nectin-4 amplification, which is the target of enfortumab vedotin, may be a opportunity for selecting those patients most likely to have the greatest benefit associated with enfortumab. And with regard to immunotherapy, it's been more complicated. I suspect that many of you have sort of watched this in terms of things like TMB and PD-L1, CD8 infiltration, other markers of potential response to immunotherapy. We've, I'd say not really been able to capture that as well as I would like to. I think that the work looking at circulating tumor DNA is certainly exciting and may ultimately provide an opportunity to select those patients who are most likely to derive benefit, as an example, from adjuvant immune checkpoint blockade, or for that matter, from neoadjuvant immune checkpoint blockade. There's been some data demonstrating the prognostic and predictive importance of circulating tumor DNA in the setting of neoadjuvant therapy as well. And I see there's another question. Is it common practice to run HER2 on bladder cancers? I don't think it's common practice. No. Do I think it should be becoming common practice? The answer is yes. I mean, certainly in the setting of metastatic disease, right? Because now that we have an approval for TDXD in this setting for patients who ultimately progress, this may represent an opportunity for treatment for these patients. And I think that, other agents are rapidly coming down the pike, as I mentioned, with disitamab vedotin as well. So I think that there's more to come with regard to HER2. I would make the comment that, we do send off sequencing on patients. The truth is, when we talk about at this very moment what we act on, we don't act on much, right? Because we act on FGFR, 3 alterations, either mutations or activating fusions, which are obviously important. But, hopefully with time we can also find patients for other targeted therapeutic interventions as well.
Okay. Well, and that's all the questions we have now. Again, Dr. Milowsky, thank you so much for joining us and presenting to our audience of North Carolina healthcare workers. Just a reminder, I also want to thank the UNC Lineberger Cancer Network team. We have Veneranda Abure, John Powell, Oliver Marth, Patrick Muscarella, Barbara Walsh, and Tim Poe.